So the first question I have is from Columbus, Ohio, and the question is, what do you see as the future of radioimmunotherapy in treating follicular non-Hodgkin's lymphoma? It seems like a very effective treatment that's not getting used enough. So that's a good point. Radioimmunotherapy is a way of attaching radiation, I mentioned it earlier, to an antibody or to a protein that then would target the radiation just to the cancer cells. And there's a couple of approved drugs of radioimmunotherapy for B-cell lymphomas. They are used and they can be effective, though they've really not caught on as much as you would think they would because they're effective therapies. I don't think I personally understand exactly why they're not used more often, but they are effective therapies, and at least one of those drugs is still available and can be used. Another question from Butler, Pennsylvania is, my husband lost the battle with diffuse large B-cell lymphoma. His strain had gene mutations, and it didn't seem that there was an accepted protocol for this situation. It can't help now, but what's the best advice for those who find themselves, quote unquote, outside the box of normal diagnosis? I think this is an important question. I'm sorry about your husband. I think what this may be referring to is something I mentioned earlier where, for instance, in terms of diffuse large B-cell lymphoma, that's the most common kind of lymphoma, but there's different people's lymphoma will have different gene expression or gene signatures, and some of those respond better and some of those respond less well to standard treatments. I think what we're learning now is that if you can identify some of those gene abnormalities and identify where standard treatments are less likely to work, you may try new treatments. I would say we don't have things for some of the more complicated genetic signatures where we know things work better, but there are ways of looking at either more aggressive therapies and really in the future, I think looking at targeted therapies that target specifically some of those gene abnormalities. I think lymphoma, again, it's one of the more common of the uncommon lymphomas, so if you find yourself in a really unusual situation, I think getting a second opinion is really helpful. There's specialty centers really all around the country, and at almost every big university or big center, there would be a person who really focuses either on lymphoma. Here at Sloan-Kettering, we have about 13 people who just see lymphoma, but even at smaller cancer centers, there's usually one or a couple people who really focus on lymphoma, and I think consultation with an expert, if things really seem unusual or are not going the way you expect, is always reasonable to do. Another question from Austin, Texas. When CTCL, so that's cutaneous T-cell lymphoma, that's an uncommon type of T-cell lymphoma that tends to present in the skin. So the question here is when CTCL presents only in the skin, can, I think, immunotherapies be used when external treatments such as steroid creams, light treatment, et cetera, have failed? If not, why not? And do you have to wait until you have more advanced stage? No, I think in cutaneous T-cell lymphoma, so that, just so people who aren't familiar with that, that's a often very indolent or slow-growing lymphoma where people often live a very long time with the lymphoma. And because people live a very long time and often don't die from it, a lot of the goals of therapy are to use milder therapies that don't really put the person at risk. And if it's only on the skin, a lot of those are what we call skin-directed therapies or treatments you put on the skin, exposed to the skin. But more and more, we're developing systemic therapies that are not chemotherapies, that don't suppress the immune system. And some of those therapies can be used in earlier stages of disease, so you certainly don't have to wait until the disease progresses to try those things. But often the question is, should you wait or not? Meaning, is the disease dangerous enough that it's worth the potential side effects or risk of any therapy? And I think at any point in time with really any lymphoma, you could ask this question. But I would say, particularly with some of the slow-growing lymphomas, there's a lot of new non-chemotherapeutic options that may be used earlier in the course of someone's disease. Next question from Massachusetts is something we get a lot. Are there any lifestyle efforts or complementary alternative medicine approaches that show promise in slowing the progression of follicular lymphoma? Not so much that we know. This is a common question. I remember a patient who I took care of when I was in training, so this was back in California, probably 13 or 14 years ago. And he was diagnosed, a relatively young man with follicular lymphoma, and decided to quit his job and just play golf every day, and his lymph nodes regressed. So that would be one option. But I think seriously, what we see in slow-growing lymphomas is sometimes that they shrink on their own without treatment. They don't always progress. Many people are observed with slow-growing lymphomas, and the lymphoma never gets worse, and observation is a very reasonable approach. So we see the lymph nodes kind of wax and wane or come up and down. And whatever you do to think you're going to keep yourself healthy seems reasonable. There's not a lot of large studies in terms of diet or certain lifestyle changes that really support that helps treat the lymphoma, though being healthy is probably good for you in general. I would say on the flip side, the only thing that we really know can harm or probably can increase the rate of growth of a lymphoma is when people have very strong suppression of the immune system. So if you have to get a kidney transplant or a lung transplant and be on medicines to tamp down or prevent rejection of your organ, tamp down the immune system, those are times where sometimes slow-growing lymphomas pick up. But short of that, we don't really know of anything that makes lymphomas grow faster or, on the flip side, grow slower. Here's a good question. It's from Sparta, New Jersey. How do you respond to well-meaning friends and physicians who question your oncologist's watchful waiting approach to your lymphoma? I leave my doctor's office and I doubt myself. It's causing this person less confidence in their oncologist. So for the slow-growing lymphomas, the indolent, the low-grade lymphomas, by and large, we have many treatments for those lymphomas that get them better. But as we said at the beginning, they're generally not curable, meaning treatments can put them into remission, but they tend to grow back. And there's right now no evidence that shows that an earlier, more aggressive treatment approach makes people live any longer, meaning you can treat them when there's minimal disease, you can watch them. In many people, they grow very slowly or don't grow at all. If they do grow to the point where they're causing some symptoms, you could treat them, shrink them down. They often stay down for sometimes years, and then you treat them again and again. And in that context, what we call watchful waiting or observation or no initial therapy is a very reasonable approach, meaning if someone has a low-grade lymphoma that's not causing them any symptoms and it's not growing, you can watch them and only start treatment at a time of really significant growth of the disease or when the disease is causing symptoms. And this approach really comes about, from understanding that while we have many treatments that work well, all our treatments also have some side effects and carry some risk. And if someone really feels fine and is in no danger, it's hard to really help them by giving them an early treatment. And if anything, you may be exposing them to the risk of that treatment, even if it's a very safe treatment that has small risk. So sometimes people will just keep an eye on. My advice would just be, I would chime in that watch and wait is a very appropriate strategy for many people with low-grade lymphoma. And if your lymphoma is not causing a problem, I think it's okay to do. I think intuitively not treating a cancer just feels wrong to a lot of people, so people say stuff like that. But at least in terms of low-grade lymphoma, we have not established that an early approach is necessarily better. Another question from Rochester, New York. I have mantle cell lymphoma. Are there any good clinical trial options? So mantle cell lymphoma is a lymphoma that kind of sits between the indolent and the aggressive lymphomas. It can sometimes grow slowly, but it does tend to grow and make people sick and can become life-threatening. Mantle cell lymphoma, there's really a lot going on right now. There's been sort of two very different approaches to mantle cell lymphoma. One has been very intensive therapy where people have given strong chemotherapy, higher doses of chemotherapy drugs like cytarabine, often following that with bone marrow transplants from people's own stem cells. And there's some large studies that have shown that that approach, particularly in younger people, can really extend people in remission a long time. We're not sure that that approach cures people. It's a little bit controversial. There are people who, after such strong therapy, are in remission 5, 6, 7, 8 years. We don't know if those people would all eventually relapse, but that aggressive approach really does get a lot of people in remission and keep them well for quite a while. On the flip side, there's a whole bunch of new therapies, and some of these new targeted therapies, the radioimmunotherapy, some of the oral B-cell receptor inhibitors, drugs like ibrutinib, some of those medications look very good for mantle cell lymphoma, and there's also a large number of trials looking at these less intensive or more non-toxic approaches. So I think mantle cell lymphoma is in some ways more than other diseases. You really have a wide range of selection in terms of clinical trials, and these trials are available at our institution. They're available nationally through the cooperative groups, and you can almost pick the kind of approach that feels right to you, obviously in consultation with your doctor, but there's really a lot going on in that disease. Question from Pittsburgh, Pennsylvania. What are the treatment options for diffuse large B-cell lymphoma only in the brain that has recurred? So lymphoma, again, can be in any part of the body. It's usually in lymph nodes, but it can show up in other organs. And there are some types of lymphoma, particularly certain types of diffuse large cell lymphoma, which uncommonly but still sometimes show up in the brain. The difficulty we have with treating lymphomas in the brain is many of our good medicines that go into the blood don't cross over well into the brain, or the body tries to protect the brain from the outside world, something called the blood-brain barrier. So there's certain chemotherapy drugs that can get in there, and there's drugs called methotrexate or cytarabine. If those are used initially and the lymphoma still comes back, radiation can be used effectively to treat lymphoma in the brain. Stem cell transplants are used often for people whose lymphoma have come back in the brain. Rituximab, which is a monoclonal antibody, can be given into the spinal fluid or in higher doses into the veins, and that can sometimes treat lymphoma in the brain. So there's a number of options. Some of those are on clinical trials. Some of those are standard therapies. It is definitely a harder area to address, but there's certainly a number of options that are available for that. A question from Miami, Florida: are massages okay for lymphoma patients? I think they are. You know, lymphomas, the concern that I've often heard is that if you do a massage, you can kind of move the lymphatics, and that might cause a cancer to spread. At least in the case of lymphoma, white blood cells like lymphocytes have the ability to travel throughout the body. They move through the blood, they move from lymph node to lymph node, they move to tissues in the body and then back to lymph nodes, and they do that normally. So they, unlike other cancers like a breast cancer or a lung cancer that needs to grow and then either get into the lymphatics or get into a blood supply to spread, lymphomas can travel from day one. So I don't really believe that massaging is going to increase the chance of that or make that worse. And if you're helped by massaging either just to feel better or it's helping with the symptom, I think that's totally fine to do. More questions. From Ann Arbor: I have anaplastic large cell lymphoma. Should I go to a specialist? Well, there's lots of specialists in Ann Arbor, so you're fortunate there. Anaplastic large cell lymphoma is an uncommon type of T-cell lymphoma, so this is one of these less common types of lymphoma. And of those uncommon T-cell lymphomas, again, about 10% of all lymphomas, there's a couple of different types, and anaplastic large cell lymphoma is about the third most common kind. It's rare. It can be cured with combination chemotherapy. There are new medicines that look particularly promising in anaplastic large cell lymphoma. So I would say, yeah, I would seek consultation from someone who has some experience with that disease. There's some subtleties to it. There's some unusual subtypes of anaplastic large cell lymphoma that show up only in the skin where you might think of a different approach. So I think second opinions probably just in general are a good thing. But whenever you have something rare or uncommon where your primary oncologist is, seeing mostly people with breast cancer, lung cancer, colon cancer, and you have an unusual lymphoma, I think it's worth getting an opinion from someone who that's more and more what they do day in and day out. And certainly we believe in subspecialization. But I think for that disease, I think that would make a lot of sense. Here's a question from Snowville, Utah. I have lymphoma. I'm on watch and wait. I'm really having trouble with anxiety and depression. Are there medications that can help for that, specifically for someone in my situation? That's a good question. And this comes up a lot. So when we talked earlier about watch and wait or no initial therapy or just observing patients with slow-growing lymphomas, the medical reason for that is because early treatment doesn't necessarily help you do any better and does expose you for some risk. But not everybody is comfortable with that approach. So if a person is really uncomfortable, really can't live with no therapy, one option would be therapy, because there's a number of safe therapies that might be appropriate to try. If you really think that's not in your best interest, for most people over time, and this is usually over months, not weeks, they kind of get comfortable with the idea. They see that their next scan doesn't look any worse. They see that they're healthy, that they're not getting sick, even though they're not on therapy. And I think the normal course is over some months, and it might be 3, it might be 6 or 9, people to kind of get comfortable with that idea, go on with their life, and then only think about it when like they're coming up for doctor's appointments or repeat scans or things like that. If you really can't get comfortable with that and you don't see an improvement in that direction, then I think getting help from a psychologist or a psychiatrist, sometimes just talking about it. There are anti-anxiety medicines, and I think those things can all help. If you really can't get comfort despite that, then there's mild therapies. And again, watch and wait is a very reasonable option. Again, because nothing's proven better, but it's also not proven that other things are necessarily worse. So I think that's something that an approach you have to be comfortable with, and often talking to your doctor can help about that. Here's another question on T-cell lymphoma. I just had from Alexander, Maine. I just had my checkup for T-cell non-Hodgkin's lymphoma. What are the chances of its returning? It's been 4 years and 5 months since I finished chemo, and they had CHOP chemotherapy. So T-cell lymphomas do have a tendency to come back, but like all the aggressive or the intermediate grade lymphomas, when they recur, most often they recur within the first 2 years. So as you get further out beyond 2 years and further out beyond 4 years, the chance of it coming back become less and less. It doesn't mean that it can't come back, but you would say that at this point in time, beyond 4 years, most of the people in whom it was going to come back would have had it come back already. So you should still be followed, but the chance of your lymphoma not coming back, I would say, from what I know here on this question, are really quite good. question from Bennington, Kansas. Are there any long-term side effects of Rituxan? So Rituxan is one of those monoclonal antibodies. It targets a marker on the surface of B cells, and it's used often by itself for slow-growing B-cell lymphomas, and then often in combination chemotherapy for slow-growing or aggressive B-cell lymphomas. It's a very safe drug, particularly compared to chemotherapy. Over time, and some people get Rituxan over time, sometimes given what we call maintenance therapy over a couple of years, it can weaken the immune system. It can cause something we call hypogammaglobulinemia, meaning the normal immunoglobulin, those proteins that are sort of one of your first lines of defense for infection, can get low, and that can expose you to some risks of infection. There have been some rare instances of bad infections coming up in people who have had rituximab or Rituxan. More often it's things like a sinus infection or respiratory infection. So that's something to look out for. And there's probably some increased risk in people who have hepatitis B, that there's a chance if you have hepatitis, that virus in your body, that can sometimes reactivate, or the body has it under control, and then with Rituxan use, it can lose control and that can flare up and sometimes needs treatment. Next question. Most webinars and research on non-Hodgkin lymphoma are B-cell lymphoma. Are there any institutions with focus on rare aggressive T-cell lymphoma? I like this is from Colorado Springs, so it's not us. I like this because my main area of research is T-cell lymphoma. So we have a very strong effort here in terms of looking at new therapies for some of these uncommon lymphomas like T-cell lymphomas, and it's something we work a lot on. I would say from Colorado Springs, there's centers around the country. There's a good group that doesn't specialize in that, but there's a good group in Denver, and there's some good oncologists in Colorado Springs I know who know a lot about these lymphomas. There's groups in Los Angeles, at Stanford in California, Seattle, University of Nebraska for places closer to you, and more and more there's new therapies for these diseases, and people are really working on these diseases. But I think you're right. Probably 10 years ago, most of the research was B-cell lymphoma, and to a certain extent there's a little B-cell bias that's still going on. Another T-cell question. I have a T-cell non-Hodgkin lymphoma that involves my skin. This is from Hillsborough, New Jersey. Are there any recent advances that could help treat this cancer? So I think I mentioned before that for a lot of people who have this, they're really fine. They're not in any danger, and you really try to use minimal therapy. But there are a number of new therapies that are being looked at in cutaneous T-cell lymphomas, other T-cell lymphomas, B-cell lymphomas, a lot of non-chemotherapy options. So that's something that there are a number of new therapies that can be looked at for that. Let's see, moving on to a few other questions. Here's one from La Mesa, California. It says, currently many European research and university cancer centers are using minimal residual disease, or what's called MRD, testing as a surveillance tool. What's your opinion of this? Do you use MRD testing for mantle cell or other lymphomas? Do you see this type of testing as playing a significant role in the future here in the US? So I think what this question is referring to is sometimes a lymphoma will be in remission, but like in mantle cell lymphoma, we think even though we don't see it by scans, we think there's a chance it can come back. And there's ways of sort of looking for the genes or trying to pull very small amounts of disease, like look in the blood or in the bone marrow and see if there's a tiny amount of lymphoma there by amplifying some of the DNA. So you can't see it with your eye, or the pathologist can't see it under the microscope, but there's other tests that give you that there's a clue there's a little bit of disease there. So this has been used primarily in clinical trials where you monitor for early recurrence, and then it's really a clinical trial question. If you have early evidence of disease coming back before you see it, and you intervene at that step, does it make a difference? So we don't do it clinically. Sometimes it's done on clinical trial, and then I think if in the future it's proven that early detection and then early treatment makes a difference, then I think it would become standard. If early detection is just early detection, but the results are the same whether you pick it up a few months or a year earlier and the treatments are the same available, then I think it probably won't be standard use. I think that's still a research question right now. Here's a question from Lorain, Ohio. It will be 2 years in January that I've had my last PET CT for follicular non-Hodgkin lymphoma, grade 1, stage 4. I've been in remission for over 4 years. I had rituximab plus 2 years of maintenance as my treatment. My oncologist will not do any more scans unless I become symptomatic. How often do you recommend either PET or CT alone once someone's in remission for indolent lymphoma? So this is an interesting question, partly because I think this is really changing. I think in years past you would see people do scans every 6 months or once a year. Rarely people would do them every 3 months and really follow people very closely. I think what we've come to understand is that cumulative exposure to radiation does have a cost in terms of perhaps causing some problems down the road more body exposure to radiation. And I think particularly for indolent lymphomas or slow-growing lymphomas, there's really very little evidence that catching it earlier on a scan changes the outcome. Meaning, even if you found a small lymph node on a scan, if the person was asymptomatic, you could observe until they grew. And usually by the time the lymph nodes grow, by your doctor examining you or talking to you or checking the blood work, you can figure out that something might be going on and do a scan. So I think this is very much an evolution. I would say right now I don't think there's a current standard. I think what we're doing is less scans than we used to. I think some people have taken a more radical approach and are doing no scans. We haven't really gone there yet, but I think as a question in the future, we'll be looking more critically at really how often we need to do scans. Follicular lymphoma, again, is sort of lifelong monitoring. It's a little different than when you're treated with a curable lymphoma and you're looking for early recurrence, where then you might add therapy to try to get rid of it a second time. Even in that case, it's not totally proven that scans help, but it's a little bit of a different situation, and that frequency is also an evolution. So our last question, sorry, we have a few, is, what did I pick here? It's tough to pick the last one. Okay. What's the most current and effective treatment for follicular non-Hodgkin lymphoma for original diagnosis and for follicular non-Hodgkin lymphoma that has returned? Okay, so follicular lymphomas, that's the second most common kind. It's a slow-growing lymphoma. It's a good question in the sense that there's not an easy answer. There's really a number of treatments, and it really depends on your goal. So we talked about not treating at all or watch and wait. There's non-chemotherapy treatment, which could be an antibody treatment like rituximab or Rituxan. That has the ability of getting someone into remission and controlling their disease with very little toxicity, though on average it doesn't control disease for as many years as if someone got, for instance, chemotherapy plus Rituxan. So if the goal is to put someone in remission for a long time, the stronger therapies like chemotherapy plus immune therapies have the best chance of someone being in remission for a long time. If the goal is minimizing toxicity, then sometimes just an antibody treatment by itself is enough to get the disease under control or put into remission, though it's less likely to stay in remission long term. So it's really dependent on your goals. Exactly the same when it recurs. If the disease recurs, it's again, what are your goals? Did it recur in a bad way that we're worried about this person and we really want to treat it strongly? And then there's chemotherapy, even stem cell or bone marrow transplants that could get rid of it for a long time or even permanently. Did it come back in a very mild way and is it not causing problems? You could just observe. That's a great time to think about new therapies or clinical trials, particularly a time where the disease doesn't have to get better in a day, but you could try something mild and see if it works. And if it works, you've gotten access to a new therapy that may be effective for you. If it doesn't work, you could usually move on to a more standard therapy. So I'm being told that our hour is up. I really appreciate your attention. It's been my pleasure presenting today, and thank you.